Thank you. It's a pleasure to be here. Pleasure to be back in New York. All right, AngioJet thrombectomy. Okay, perfect. These are my disclosures. So to start off, AngioJet thrombectomy device, a rheolytic thrombectomy device that works with the Venturi-Bernoulli effect, where you have high velocity, high pressure saline injected through the catheter, causing a low pressure system within the catheter and resulting in the vacuum effect and entrainment of clot and debulking of thrombus. You also have the ability to go in power pulse mode, which allows delivery of lytic directly into the clot and allows to soften up the fibrin and break down the clot further. Comes in several different catheter sizes. So you can start with the Solent or Dista, which is typically used in arterial thrombectomies, and the Zolante DVT is what we typically use for venous thrombectomy. It's 8 French size. So you can see the catheter and the console that powers the device. There have been several trials. We just heard about the ATTRACT trial, and here's a review paper from 2011 that essentially looked at pharmacomechanical thrombectomy, including AngioJet, in comparison to CDT, where they looked at the amount of clot removal was essentially similar. However, significant reduction was noted when you look at use of hospital resources, catheterization, infusion time, and the total dose of thrombolytic delivered. So basically potentially reducing adverse bleeding events. Recently, a meta-analysis was published looking at AngioJet thrombectomy versus catheter-directed thrombolysis. And again, what we saw was there was no significant difference in the effective rate and complications. However, there was a significant decrease in the incidence of PTS and Villalta score, as well as low severity of PTS was noted in the pharmacomechanical or AngioJet thrombectomy groups. There was also a statistically significant decrease in the duration of treatment and the drug dose delivered. Clicking away. Just so many clicks. The Pearl Registry data. So Pearl 1 and Pearl 2 essentially followed patients out after AngioJet thrombectomy. Pearl 1 looks at 3-month outcomes, Pearl 2 through 12 months, and you can see the spectrum of patients treated here, including arterial hemodialysis access as well as deep venous thrombosis. What they saw within the DVT patients was that there was a 34% of the patients were treated in a single session, about 88% were treated in 2 sessions, 75% of the procedures were completed in less than 24 hours, and they noted a less total lytic dose for treating DVT when using the power pulse or rapid lysis in comparison to catheter-directed thrombolysis, and this was presented by Dr. Garcia in 2013. So what are the limitations of using AngioJet thrombectomy device? Typically, we may notice transient bradycardia during the procedure that usually allows, or that usually causes us to essentially pause the procedure, just stabilize the patient, and then continue on with the procedure. There have been reports of acute kidney injury in certain patient cohorts. With emerging new technology, large bore aspiration catheters, especially catheters with things like coring elements that may reduce overall interprocedural time, be used to treat subacute and/or chronic clot. Where do we see the use for AngioJet at this time? And that's going to be discussed in my next couple slides, as well as our effort to reduce blood loss. We have all of this new technology coming in with competitive devices that, such as the Flow Saver with Inari and or the Lightning technology with Penumbra. I'm sure we will go over those in the next couple talks. Where do we see AngioJet fit into that paradigm at this time? So I think there's still a role for AngioJet in the current climate when treating thrombus in the venous space, and that particularly in the in-stent thrombosis cases, filter-related thrombosis, Porto-mesenteric thrombosis, as well as dialysis circuit thrombosis. And here are all of the competitive devices, and here's AngioJet Zolante. So this slide essentially shows the enhancement that Boston Scientific just introduced. It's the Clot Hunter. Essentially is a physician-controlled thumb wheel that initiates rotational movement of the catheter tip and essentially allows for 330-degree coverage of the vessel lumen. So it leads to shorter run times, reduced rates of hemolysis are likely associated with this, and it would lead to better success in a single session. So this is the first case, 60-year-old female. She had acute left lower extremity DVT. Essentially, she has presence of iliocaval stents, went off of anticoagulation. What we see is thrombosis of the stent and the common iliac segment on the left. So this patient was brought to the IR suite and was basically accessed prone. The popliteal vein was accessed. The clot was essentially traversed with the wire catheter combination. Initially, a Zolante device was used to power pulse TPA. After 30 minutes of dwell time, the Clot Hunter device was introduced. And I don't have all of it on this image, but essentially that's how the Clot Hunter device works, is because of the helical motion of it, you are essentially debulking larger amount of clot, and for example, this large vessel lumen within the stents. And I had a final. So essentially, for the interest of time, I'm just going to keep moving on. Sheets were removed. Patient procedure was completed in 1.5 hours. Patient was discharged basically the next day. So on bench testing, they saw that Clot Hunter removed 60 to 80% more thrombus than Zolante DVT alone. They also noted when in comparison to Penumbra Indigo CAT8 that within the same amount of runtime, greater amount of clot was removed. Again, this is bench testing. This is not clinical tested data. Here's another case, 65-year-old patient presented with complete porto-mesenteric thrombosis. Now, in these cases, we typically would provide patient with a TIPS procedure, but in order for the TIPS or the stent to stay open, we need to create better inflow and outflow. And in that case, we would, go in with device such as the AngioJet Zolante, which is an 8 French system to essentially open up the SMV branches. However, in this patient, these images are from post-op day 3. He occluded the TIPS in his entire porto-mesenteric system again and was brought back for thrombectomy. So here is the anatomy of the porto-mesenteric confluence. Essentially the TIPS stent is partially covered, partially uncovered. And in this situation, because there was a large amount of clot and we needed to get everything done efficiently, Inari catheter was used for the iliocaval segments, but the limitation of Inari catheter and the TIPS is that essentially the catheter is typically an 8 millimeter outer diameter and the TIPS is typically 8 to 10 millimeters. And in order to prevent fracture of the stent or damage to the parenchyma of the liver and or fracture of the catheter itself, something like AngioJet is a much lower profile device and can get the job done to restore inflow to the SMV and portal system. So here's a Zolante device, and we selectively went into each of the branches and restored the flow. Here's the patient after. I'm at 1 minute. Another use for AngioJet in the hemodialysis patient population. So the Pearl Registry had 145 patients, 186 treated vessels, and what they saw that there was 78% patency at 3 months. The KDOQI current guidelines for KDOQI minimum goal is 40% at 3 months. So another place where AngioJet might essentially make your procedure efficient. So in summary, compared to CDT, there is reduced use of hospital resources, catheterization and infusion time, total dose of thrombolytic delivered. With large bore devices, there is current controversy regarding should we be going after chronic clot, or is there vessel or valvular damage? And we need more research to evaluate these devices perhaps in a prospective comparative trial amongst all of them. Cost may be a consideration, and then using the enhancement of Clot Hunter along with Zolante might be, you might be able to get more challenging acute and subacute cases treated. And so I still think that there's a role for AngioJet in the current climate and the current venous space, and that's typically an in-stent thrombosis, filter-related thrombosis, porto-mesenteric thrombosis, and dialysis circuit thrombosis. Thank you.